All right, it's 8 o'clock, so we'll go ahead. So, welcome everyone. This is the first grand rounds of 2024, and it's a very appropriate talk for post-holiday grand rounds. So we're having two speakers today. One from our Department of Medicine, one from the Department of Surgery. From the Department of Medicine, Dr. Andy Spiel will be speaking. He is a graduate of Tulane University for his undergrad. He went to University of Illinois for medical school, and then did his residency and fellowship at the University of Wisconsin. He did special training in endobariatrics at the University of Colorado, and he is an assistant professor in the section of gastroenterology and hepatology. He is the director of our bariatric endoscopy program. He did the first ever endoscopic sleeve gastrectomy at University of Wisconsin. He did the first ever transoral reduction endoscopically of a gastric bypass patient at UW, and he is established our endoscopic bariatric program here at UW. He'll be joined as our second speaker by Dr. David Harris from the Department of Surgery, but it looks like you also have a affiliate member with endocrinology as well. So you are part of it as well, David, so thanks. David went to college at Bucknell in Pennsylvania, medical school at University of Virginia, and then did residency and fellowship at the Brigham and Women's in Boston. And his main interest, just as Andy's is really surgical and treatment of bariatric and obesity. And he already has published at least 20 publications, primarily on how surgery affects metabolism in patients who suffer from obesity. So they actually, I was saying, they actually have accomplished the first goal of any grand round with a really great title. So they'll be talking, and the name of their talk is New Year's Resolutions Beyond the Gym, Approaches to Obesity and Metabolic Disease. So David and Andy, welcome, and it's all yours.
Awesome. Well, thank you for the invitation to speak here today, and I'll kind of get things started. So you didn't get to see the fun title, but anyway. All right, so the goal is to discuss the trials and tribulations of dieting and review how metabolic surgical operations affect both weight loss and then other organ health and disease processes. And I'll review some of the clinical data as well as some of that I find the most interesting basic science research. So when we think about weight loss, this is typically what we think about in our country and other Western countries, is that it's just a willpower problem. You just walk more, exercise more, eat less, and you'll be successful. But this was kind of well highlighted in the New York Times a number of years back, that, it's not a willpower problem. And so they followed the, quote, Biggest Loser competition patients for 8 years, and they looked at really what happened to those patients. And so when they all started the competition, they were all at their baseline weight. And by the end of the competition, pretty much everyone lost weight. But you can see over time, over 6 years, everyone regains a lot of their weight, and particularly the patients here. You can see two patients kind of won out in the end at 6 years. Is Erin, who kind of was the worst Biggest Loser, was slowly able to change her weight over time. And this patient, Rudy Pauls, who at this point ended up having a sleeve gastrectomy and lost a bunch of weight again. And the reason that this occurs is that the body does not like to lose weight. The body likes to maintain the weight that it's at. And so it reduces energy expenditure over time. So this is a graph of energy expenditure and their metabolism at 8 years. So you can see this person, the Biggest Loser, ended up burning 800 fewer calories a day at 6 years than a person that was of their size should. So the body really likes to defend its set point, and it's good at doing that. So really, as Dr. Rosenbaum was quoted, the difficulty in keeping weight off reflects biology, not a pathological lack of willpower that affects 2/3 of the United States. Later, Dr. Hall kind of reevaluated what happens in this metabolic adaptation. And what he found is that if you increased your energy expenditure through activity greater than 80%, you had the most metabolic adaptation at 6 years, which is really conservation of energy, thermodynamics. You're going to conserve your energy as a whole. So if you're increasing in an activity, you're going to reduce that in your resting metabolic rate. So what are kind of other weight loss therapies? If it's a biology problem, most people are going to need an adjunct to help them lose weight. And you've already heard about medications in October, and you'll hear today about kind of the two other adjuncts. And so what are our options? Again, normal anatomy, esophagus, stomach, small intestine. And when we do a sleeve gastrectomy, basically we permanently remove 75% of the stomach, leaving a more narrow tubular stomach behind. Gastric bypass is really different. Nothing gets removed. We make a small pouch out of the stomach, and then we reroute the intestines from down here up to that pouch, such that food follows the green and bypasses everything in pink. And this represents about 60 and 40% of the operations. There are other bypasses out there that are really not covered by the Wisconsin insurance market, but represent a real minority of the cases done. And patients get about 25 versus 30% total body weight loss. This is one of the new kids on the block called a SADIES, which is essentially you're combining a sleeve and a bypass together. Outcomes are quite great. Unlike one of the other operations, the duodenal switch is associated with less risk of malnutrition, but we're not currently doing this here. And is bariatric surgery and calorie restriction different? The answer is very different. They lead to different physiologic changes. Bariatric surgery increases energy expenditure, decreases appetite, hunger, increases satiety, and has a major effect on the incretin hormones, whereas calorie restriction does not, just as I kind of mentioned earlier, but we won't get into that too much. And multiple trials over time have shown that bariatric surgery is the best therapy for obesity and obesity-associated conditions with long durability over and over again. And this is, I kind of wanted to show you what the weight loss trajectory typically is. So this is 10 years on the x-axis and change in percent total weight. And you can see really the maximal weight loss occurs at a year and a half. And this is a very, very reproducible number. This is about 5,000 patients. You can see everyone gains weight a little bit over time, but tend to stay less than that 20% weight change over time. And, if we look at other operations, the duodenal switch and the Roux-en-Y gastric bypass, you can see, the same weight trajectory. About 36 months, they're kind of coming up to that additional weight added on. But I want you to notice that patients still remain with obesity. So you have a year and a half to drive that weight loss, and that's it. And really, this is a reproducible number. Why that happens, we don't really know. But it also happens with medications, right? So this is semaglutide. You could see 68 weeks, that's it, no more weight loss. And the same with the oral GLP-1 agonist and tirzepatide. This is a really reproducible number, and it still leaves patients with obesity. And why we can't break that plateau is unknown. Now, the question has already come up, well, what about recurrence? So we talk about now not regain, we talk about recurrence. We're trying to use the cancer verbiage to talk about this. But so on the left here is sleeve gastrectomy. And this is basically they establish recurrence as when you cross that threshold back to less than 20% total body weight loss. And you can see with the sleeve, that total population, there are a lot of people who cross that threshold over 10 years of follow-up. There's still a subset of patients that were able to maintain their weight loss, but you can see that weight regain is quite high, but not back to baseline. As comparison, this is the semaglutide trial, and you can see when patients lost access after that 52-week or 68-week treatment phase, everyone had weight recurrence, and no matter how much weight you lost up front. And so when I talk about or think about this, scientifically and in the lab, what we study is, well, where can we intervene to drive weight loss? And we have kind of proposed a number of interventions in this time frame to help drive that plateau, to really kind of break patients back through that barrier, which we won't get into too much. But it kind of, is it combination therapy? Is it postoperative diet? Is it postoperative exercise? We've been studying that. But likely you're going to be most impactful at number one, when patients are having a physiologic adaptation that you can bolster. So now I kind of want to switch gears and talk about some other disease processes and organs to how bariatrics affects that. So in humans, after bariatric surgery, they have rapid changes in their glucose physiology. So all comers in this study that we performed, all patients with diabetes come in on diabetes medications, whether it's one therapy, two therapies, or insulin or more. And you can see at discharge, 40% of patients leave without their medications, and they really never go back on. So only the number of patients off of medications at 12 months only increases. And this phenomenon is greater in gastric bypass, but not by much. But really, there's a thought in the field that there is both a weight loss independent and weight loss dependent change in glucose physiology. And we know that actually at the level of the islet, things are really changing. So in this study by Dr. Alessio's group, they did sleeve and sham operations in DIO, diet-induced obese mice. And they looked at islets that were ex vivo explanted, and they see that islets exposed to 10 millimole of glucose actually have increased insulin secretion compared to sham counterparts. And this is just shown here in different ways, area under the curve, an increase in calcium signaling within the islet itself. And it happens without changes in beta cell mass or insulin content. So it really is a release from the islet. And we've shown this, and others have kind of re-shown this data. So clinically, can we cure diabetes? And the answer is yes. And so the Stampede trial is the seminal trial. It's basically 3-group randomization controlled single center study at Cleveland Clinic, 150 patients. They were randomized to intensive medical therapy, gastric bypass or sleeve gastrectomy, and they were stratified according to the baseline use of insulin. Everyone had an A1C greater than 7. The BMI criteria actually was as low as 27 up to 43. And the strategy was intensive medical therapy with adjustment of meds every 3 months for 2 years and 6 months thereafter. And the primary outcome was A1C less than 6 without diabetes medications. And this is essentially med therapy, gastric bypass, and sleeve in these columns. And you can see the number of an A1C less than 6% without medications in the medical therapy group is 0. And that's at all A1C stratifications. But you can see 38% and 24% met the primary criteria for gastric bypass and sleeve gastrectomy at 3 years. And then, patients who have better control and on medications are also higher in the gastric bypass and sleeve gastrectomy. And at 5 years, this kind of still holds true. And, I think one thing of interest, we think of, bypass operation as the better metabolic operation, but you can see really at that 5-year mark, they're pretty similar, if not identical. And the BMI difference between the two groups is really not that high. While there is a difference, we're talking, 15 pounds for most patients that can expect that difference. And this is the durability of improvement. So this is by Mangaroni's group, and this was 10-year indices published in the Lancet, med therapy versus BPD, or biliopancreatic diversion, or gastric bypass. And this is that 10-year data. So fasting glucose between, again, in millimoles per liter, because it's English and they have to be difficult. But you can see that both the bariatric surgery groups have much better fasting blood glucose, A1C, HOMA-IR, which is a measure of insulin resistance, and higher diabetes remission. You can see 0 0 remission in the medical group versus 50% and 25% in the bariatric surgical group. So it is a durable improvement in diabetes. Switching gears a little bit, well, let's look at how does bariatric surgery affect cancer. So this is the Splendid retrospective observational matched cohort study of adult patients with BMI of 35 or greater who underwent bariatric surgery, again at Cleveland Clinic, between 2004 and 2017. and they had about 5,000 patients matched 1 to 5, with patients matched at the BMI of time of surgery. Their primary outcome was esophageal cancer, renal carcinoma, postmenopausal breast cancer in younger patients, colon, rectum, liver, gallbladder cancer, basically cancer of other types. And the 2 secondary endpoints are cancer-related mortality. And you can see basically at 10 years, both sleeve gastrectomy and Roux-en-Y gastric bypass compared to non-surgical controls had a reduced cumulative incidence of cancer of all cause. And this is further shown here as a combined group. You can see bypass and sleeve are not really different. And at 10 years, bariatric surgery outcompetes non-surgical controls. And then interestingly, this stratifies based on how much weight loss. So they did quartiles of weight loss. So the higher the weight loss, the less your cumulative incidence of cancer. And this was, I think, a really interesting study. They looked at response to immune checkpoint blockade in bariatric surgery in mice. And Joe Pierre is actually in the Division of Nutritional Sciences here at UW. This was published when he was at Tennessee. But basically, they took lean and DIO mice, they weight matched them, did sleeve or sham operations, and they injected breast cancer into the mammary gland of mice. And they looked at basically what happens to PD-L1. So you can see if we just focus on the red, in high-fat diet sleeve animals, there's increased expression of PD-L1 in macrophages. And this is really important because then it opens up to PD-L1 blockade in a tumor that you don't normally use PD-L1 inhibitors for. And again, just focusing on the red, when you give a sleeve animal anti-PD-L1 therapy, you can see that their tumor volume decreases. So not only is it exposing PD-L1 in the tumors, but you were able to intervene upon that. And this is just looking at that tumor volume. And we published that the entire B-cell repertoire changes after surgery, and it's not unfathomable that these things will also change. So switching gears a little bit in transplant, we have a lot of co-cases with patients who require bariatric surgery to get them in position to have a transplant because their weight is too high to be a candidate. So this basically looking at patients with end-stage renal disease. You can see that patients receiving bariatric surgery had a reduced all-cause mortality at 7 years compared to non-surgical controls, and their likelihood of receiving a kidney transplant pretty much starting at year 3 is much greater than those who did not receive bariatric surgery. And I think interestingly in the bariatric surgery primary literature is, well, does this affect graft function? If I told you that it changes the immune system, can you affect graft function? And this was a study basically in skin grafts where they used isogenic, so shouldn't reject, versus allogenic, should reject. And you can see that sleeve animals here had a higher graft survival compared to allogenic obese animals. And so this is graft survival over time in sleeve versus the allogenic animals. So, you know, not only probably are we affecting the candidacy for someone to get a transplant, but we probably are also affecting long-term outcomes. And so something near and dear to my heart, which we study in the lab, is aging and cognition. And so in this study of 174,000 participants, they looked at what happens to lifespan, not health span, but lifespan. And you can see compared to non-surgical controls, patients who've had metabolic surgery over time, over the 30-year, had a reduced cumulative mortality. And interestingly, if it's stratified based on those with diabetes and without diabetes, those with diabetes actually had stand to gain more life years. And so that it turns out to be roughly 10 versus those without diabetes, roughly 5 years of life. And the sooner you get to someone, actually, the better. And so that kind of goes into the adolescent literature, which I won't get into today. This is a really interesting figure where they essentially look on the z-axis, increase in metabolic surgery uptake among bariatric candidates with obesity and diabetes and without diabetes on this axis. And this is the global life years that you stand to gain. So for every increase, 1% increase in surgery, there's 6.6 and 5.1 million life years gained in those with and without diabetes. So a really, really profound statement, how much life that patients stand to gain across the world just by increasing bariatric surgery uptake. So, health span is something I'm interested in. So yeah, you get more years, but are they better years? And one of the things I'm really interested in is memory and Alzheimer's disease. And this kind of small clinical study, they looked at improved memory function in patients who underwent bariatric surgery. And so they took, roughly 50 patients per group, bariatric surgery patients versus controls. And you can see that they're pretty well matched, other than the bariatric patients tend to be a little heavier and have sleep apnea, which can certainly affect memory, as you all know. But when we look at executive function, memory, and language at 12 and 24 months, all patients with bariatric surgery improve their scores compared to their baseline selves across all domains, language a little less than memory, and attention and executive function. And then when we compare surgery versus controls at 24 months, they do score better in all in attention, executive function, and memory. And so the question is, well, if we can affect memory, can we really affect Alzheimer's disease, which isn't the same, obviously. And in this group, they just basically did a small clinical pilot study, and they looked at amyloid precursor protein within mononuclear fraction, and then other pathways that affect accumulation of amyloid precursor protein. And sure enough, after bariatric surgery compared to their selves, they had reduction in all the parameters listed there. And so we embarked on a study in mice. We used two mouse models of Alzheimer's disease, and I'll kind of present the female 3XTG model. So this is a model of early onset Alzheimer's, which clearly isn't the same as what most people get. We performed sleeve or sham operation over time. We did metabolic phenotyping, and then cognitive testing serially towards the end of to the end of the experiment. And what we can see at 6 months of age, and so that's roughly a quarter of a mouse's age, sleeve affects frailty. So you have a reduced frailty in surgical animals, and improved long-term memory in novel object recognition tests. And that still happens at 12 months of age, despite there not being a difference in glucose handling. So, these mice are on Western diet their whole life, and so they can out-eat their sleeve, and they are similarly obese, but they still are less frail. And then when we look at Barnes maze test, or an ability to find an escape hole in a maze, sham versus sleeve animals are very different, where 3/4 of the sleeve animals find the hole, and a supermajority of the sham animals can't even find the hole, whether it be short-term or tested a week later in long-term. So we are clearly affecting memory. This study is ongoing. This data is just from last week. So we're looking at Alzheimer's specific pathology and mechanisms which might lead to this, but really exciting stuff. I think the one system I'd be remiss, like it can't all be good. The one system we negatively impact is bone health. And this is particularly the case in Roux-en-Y gastric bypass. And so this is the survival probability without a fracture over time. You can see that, no surgery versus banding, which, doesn't occur anymore, in sleeve gastrectomy. Roux-en-Y gastric bypass has an increased risk of pathologic fracture over time. And this is a meta-analysis of multiple studies that basically show that same thing. If you have a malabsorptive procedure, which is any bypass, malabsorptive being a misnomer in my mind, you can see that there's an increased risk ratio of having a pathologic fracture over time. And so our societies now recommend actually doing bone health screening, whether it be DEXA scan or labs, every 2 years in patients who've had a malabsorptive procedure. And why does this occur? Well, probably a lot of different things. There's a preclinical study looking at the IGF pathway and how that specifically affects bone health. So it's probably not just that it's a calcium vitamin D problem, but there's a lot of things that occur that affect bone health. So just in terms of our comprehensive weight loss program, what happens? Well, who gets surgery? Well, this is the new guidelines from our American Society for Metabolic and Bariatric Surgery. They basically recommend bariatric surgery for all patients with a BMI of 35 or greater than 30 with metabolic disease, and particularly lower thresholds for patients of Asian descent, because they have diabetes at lower BMI cutoffs. Now, I think the criteria that insurance companies like is the NIH criteria, which is a little bit more stringent. It's BMI of 35 with a comorbidity or 40 without one, which really does a disservice. Courts has now kind of more towards this new guidelines. If you read who they'll cover, but not every insurance company is the same. And, bariatric surgery across the board, there's a big uptake, but we're still, even by 2009 standards, we're not doing that many operations worldwide. But our numbers here in the state have really increased. Dr. Funk and Dr. Guerin were lobbying, who were both my partners, lobbying on at the Capitol for coverage for state employees. You can see roughly around this time, we've gone from 200 cases a year to we have really, almost 750 cases projected this coming year. And we have about 950 active patients in the program, which is just a staggering increase. Our comprehensive program, you meet with a health psychologist, a dietitian, a surgeon, and we have a bunch of APPs in the group. And I'd say every part of this is really, really important. The surgery is kind of the tool, but the health psychologists and the dietitians help build long-term healthy habits. A lot of our patients come in with dieting mentality, which is a problem. We don't want patients dieting after surgery. We want them to have a healthy relationship with food, able to eat 3 meals and 2 snacks for the rest of their life. They have a bunch of small group sessions. Specific in our program, we have an intuitive eating courses for patients that have binge eating disorder or require a little bit extra counseling in their eating, for eating. We often have them work with outside psychology and psychiatry. And then we try to downstage obesity with medications if they can get access or if needed. And again, we can probably drive their weight nadir if we can downstage their obesity. So in conclusions, metabolic surgery is safe and effective. I didn't show you that. Surgery, complication rate, there is about as safe as getting an inguinal hernia repair or, getting your gallbladder out. So really safe. Weight loss is long-standing for many. It broadly affects the health of all organs and it can improve age-related diseases. All right, next I'll hand it over to Andy, Dr. Spiel here.
All right. Well, thanks, Dave. It's going to be hard to follow. It was a great talk. All right, so I'll share here. So hopefully this is working. So yeah, what I'm going to talk about next is as a gastroenterologist, what we can do to help patients with obesity and metabolic disease, and specifically going to be talking about endoscopic bariatric therapies today. My objectives for this part of the talk, hopefully you can understand some endoscopic tools for weight loss, understand some of the mechanisms, at least the ones we know, behind these tools, and overall introduce you to a field you may not have ever heard of called bariatric endoscopy. So again, Dr. Harris touched on this. So obesity affects in the United States alone over 100 million people, 100 million adults. And of those, only a fraction, less than 1%, 1% are getting bariatric surgeries. Fraction of those are also being treated with pharmacotherapy. We are seeing more and more utilization of pharmacotherapy, but still, this is leaving us with a significant amount of patients who are not treated for obesity in this country. What I wanted to talk about today, bariatric endoscopy. And so this slide basically goes over these different groups of devices and tools we have endoscopically to treat obesity. What you'll see here is space occupying devices you may have heard of, such as balloons. I'm not going to spend a lot of time talking about those today. The durability data for these devices just isn't there. Most of them are removed after 6 months or 12 months, and you see recurrence of weight in those patients. Here on this side, we have non-intragastric balloon devices. You may have heard of the Aspire Assist, where you actually remove your meal via like a peg tube after eating. That's no longer on the market. And there's other devices such as pyloric shuttles we'll not get into today. And then small bowel therapies there at the bottom, which have weight loss independent effects, but are really not great tools for weight loss. Those include things like bypass liners and duodenal resurfacing. So what I'm going to focus on today is talking about suturing devices. In particular, my focus is going to be on endoscopic sleeve gastroplasty, and I'll show you data about that. So hopefully this video plays here. So this is the endoscopic sleeve gastroplasty. And basically what you're seeing here is inside of a stomach and marking with APC of the greater curve of the stomach. Then a suturing device is put down via an endoscope, and the stomach began to suture in this U-shaped pattern, and it's just repetitive over and over in order to cinch that part of the stomach, that greater curve up, to create a sleeve configuration. When it's all said and done, we probably do 4 or 5 of these U-shaped patterns, and the goal is to reduce the stomach by about 70% of its volume, as you see here. So here's the endoscopic look at a ESG, I'll refer to it as. Before, you have the markings there with APC, and then after the suturing, you see that nice tight sleeve configuration. This is an FDA-approved treatment for obesity, and patients who qualify would be BMI greater than or equal to 30. You see total body weight loss in this population of patients undergoing ESG of about 15%. And I have some data showing you that these numbers are sustainable and durable, which is really important. This is an outpatient procedure. So patients come in, get an ESG, and they're home the same day. And it is safe and effective, as I'll show you as well. I did want to touch on physiology a little bit. A lot of this is unknown, but the one thing we do know is that endoscopic sleeve gastroplasty does have an effect on gastric emptying. And this effect is desirable and likely leads to weight loss via prolonged increased satiety. So as you'll see here in this graph, on the y-axis, you have gastric emptying times. You have the control group here on the left and the ESG group there on the right. What we see, the different colors represent different timelines. So at baseline, they're both essentially equivalent, gastric emptying is. And then after ESG at 3 months and 12 months, you see here that delayed gastric emptying, so the time it takes for the stomach to empty, is prolonged and sustained. The hormonal effects of this are a little less understood. This same study took plasma levels of things like GLP-1, PYY, ghrelin levels. And what we saw was ghrelin levels seemed to increase, PYY and GLP-1s remain largely unchanged. So we don't really understand what hormonal effects contribute with the ESG. And we do know that this is a different mechanism than a laparoscopic sleeve gastrectomy. So we're not removing any part of the stomach. And I think it's important to understand that, you know, those mechanisms that Dr. Harris was talking about, especially a lot of those hormonal effects, we just do not see necessarily with this procedure. Laparoscopic sleeve gastrectomy actually increases gastric emptying time. So decreases it, more rapid gastric emptying. So I wanted to talk a little bit about endoscopic sleeve and the efficacy. And so here is a meta-analysis of over 1,700 patients showing weight loss outcomes at 12 months, again, being higher than that 15% at about 16.5%. And then they even had a couple of studies go out as far as 24 months, showing that that is sustained at about 17% total body weight loss. We also need to talk about safety of these procedures. And like Dr. Harris said, surgical procedures are very safe. Endoscopic sleeve procedures are very, very safe as well. You could argue that they're even potentially safer. But in this meta-analysis, the severe adverse event rate of these procedures was about 2.2%. About half of those patients just required hospitalization because of pain or nausea, which is super common after this procedure. And then the additional 1% of patients had some other complication that likely needed to be intervened on. There were no deaths reported, which is also important. So this is my son Cameron when he was 3 months old, and his look here is exactly how a patient feels after getting an endoscopic sleeve. They feel miserable, and the more you tell patients up front how they're going to feel in the coming days after, the better they do, and the more you can kind of get them all ready with antiemetics, fluids during the procedure, the better they do. This really only lasts a couple of days typically, and then patients really feel better. He doesn't look like this anymore, but he's still he can still give me that look sometimes. Anyways, so how does ESG hold up for versus other modalities of weight loss? So ESG compared to high intensity diet and lifestyle therapy in this study out of Johns Hopkins took 135 patients who underwent ESG and then 280 patients with a high intensity diet and lifestyle. Of note the ESG patients only had a low intensity diet and lifestyle therapy in addition to their ESG versus this high intensity therapy. At a year, we see ESG patients at 20% total body weight loss versus 14% in the high intensity diet and lifestyle therapy group. And that 14% number is honestly astronomical for any diet and lifestyle therapy data that's out there. As Dr. Harris alluded to, typically that's not sustainable, and those patients, will likely regain weight in the long run. Of note, 90% of the ESG patients had a greater than 10% total body weight loss. That number you'll see again, that 10% total body weight loss, that's the number we use to really predict reduction in morbidity and mortality associated with excess body weight. So you'll see that number again. So here's ESG versus laparoscopic sleeve gastrectomy. How does the ESG fare? Well, in this retrospective study comparing 54 ESG patients to 80 LSG patients, we see total body weight loss of the ESG group at about 17% versus 23-24% in the surgical group. And so this graph's a little tricky to read, but basically the blue line here represents the endoscopic sleeve gastroplasty, and the orange line is the laparoscopic sleeve gastrectomy group. And there is some variability here, but in general, the goal was just to say that ESG is efficacious, but not as efficacious as LSG. But again, just kind of confirming those numbers. So that brings us to kind of the biggest landmark trial, the MERIT trial, which is what led to the FDA approval of this procedure. It included 9 US centers, 209 patients were randomized in a prospective fashion to lifestyle versus the endoscopic sleeve gastroplasty. At 52 weeks, we see outcomes of total body weight loss of about 14% in the ESG group compared to less than 1% in the control group. So the inclusion criteria for this study included patients with BMI of 30 to 40. There was a crossover at 52 weeks, so those patients in the control group could get an endoscopic sleeve gastroplasty, and that's what you see here with the red group. Those are the patients who underwent ESG patient at the 1 year, or ESG at the 1 year mark. And one thing to note is that this was amidst the COVID pandemic, and that may be an explanation for why those numbers weren't as high as we saw in some of those other studies I was showing you. Just more disjointed follow-up and things like that. Not to mention there is data suggesting the COVID pandemic did lead to patients having more difficulty losing weight in general. Safety data from this study, again, the same as the meta-analysis I showed you, just 2% severe adverse event rate, GI bleeding, abscess, or an intolerance to the procedure requiring reversal. And I think it's good to note with this procedure, it is technically reversible. So we can go there. So after time, there is scarring of that stomach into that sleeve configuration. But in the short term, we can actually go in and cut sutures if patients are truly intolerant, and that will lead to some gastric re-expansion. So it is potentially a reversible procedure as well. So the other thing I wanted to focus on is what are the secondary outcomes? So obviously weight loss is important and we know that, but are we actually improving comorbidities? And in the MERIT trial, they showed that as well. Looking at the diabetes patients who underwent ESG, 92% of them have an improvement in their diabetes compared to 15% in the control group. And if we look at multiple comorbid conditions, which include things like diabetes, dyslipidemia, hypertension, NASH, we see improvement in at least one of those conditions in 80% of people undergoing ESG. And I always like to talk about durability because I think that is very important. So the ESG does have 5-year data showing durability. This is a single center out of Cornell, 216 patients. And at the 5-year mark, we see approximately 3/4 of them having a greater than or equal to 10% total body weight loss sustained. Here's that graphically. And the one caveat I will say about this is in about 1/4 of the patients in this study, they did use an anti-obesity medication at some point following ESG. And I think that's important because, as I'll talk about in a little bit, that may be where the future is of these procedures. Giving medications are becoming more available and widespread. So to, again, discuss durability, ESG, you see 5-year outcomes here, and semaglutide. I wanted to include this because essentially ESG is not subject to volatility in the market or changing insurance, pharmacy stock, anything like that. And so it's important to know that, when patients, whatever they may be choosing, stopping medications will lead to weight regain. And so I think that is a significant thing to note when we're talking durability and sustainability. So that brings me to the future. I think there is a role for endoscopic procedures and surgical procedures combined with medications. This was a study essentially showing that you get better outcomes with the combination than either alone. So this had 26 patients in each arm. It was retrospective, but all patients were offered liraglutide at 5 months. Those that accepted the liraglutide were followed 7 months after that and had the ESG, the combination between ESG and liraglutide. You see about 25% total body weight loss in that group compared to the ESG alone, which had about 20% total body weight loss. So, again, I think with all these discussions we've had with Dr. Pavik talking about medical therapy around Halloween, Dr. Harris, myself, understanding obesity is that it is a multifactorial disease and it requires a comprehensive multifactorial approach to treatment. I'm not going to belabor this too much, but we know that all these components work together to help patients truly lose weight and to keep it off in the long run. So what I provide endoscopically, it's simply a tool. It's not the entire answer. We need a whole team of people in order to do this. And this is just kind of data supporting that in the ESG literature. So these are patients who all underwent ESG. And you see here, basically, it's kind of a weird way they graphically displayed this data. but on the y-axis here is the mean percentage of whether it be BMI loss, percentage total body weight loss, or excess weight loss. These are all essentially equivalent columns, but you see based on their adherence, low, medium, or high, they have higher success the more interactions they have with nutrition and psych, which leads to increased weight loss. So I also wanted to talk about expanding applications of endoscopic sleeve gastroplasty into patients with class 3 obesity. This was a study done with 400 patients with BMI greater than or equal to 40, and they all had maintenance of 20% total body weight loss at 36 months with an incredibly low severe adverse event rate. So this is really an option for those folks not eligible for bariatric surgery to benefit from something. So the last thing I want to talk about is one of the few times anyone like Dr. Harris ever calls me for help. But it would be, what do we do with weight regain, or what we should really call recurrence after bypass? So this does happen, although it's not the majority, but a minority of patients will have significant weight recurrence after a gastric bypass. And this study shows that the diameter of the gastrojejunostomy actually correlates with weight regain. This was 165 patients who had weight regain of at least 20% of their weight lost. They all underwent an endoscopy for clinical reasons, and they measured that outlet diameter, so the gastrojejunostomy. And they showed that this was a risk factor for weight gain. So the procedure I can offer using the same device I use to do the endoscopic sleeves with, that suturing device, is a transoral outlet reduction, or a TOR procedure. And essentially what we do in this procedure is we just suture around the anastomosis in a purse string fashion to decrease the diameter. And this leads to weight loss in these patients. So here's the endoscopic view. This is the anastomosis prior to doing a TOR procedure. And you see here, I mean, this is a diameter of at least 30 millimeters. And after the procedure, we've shrunk it down to probably more like 8 millimeters. And the 5-year results of this in 330 patients showed a final gastrojejunal anastomosis size of about 8 millimeters, give or take. And there were no severe adverse events. Patients lost about 8 to 10% of their total body weight in those who had regained following bypass. And I'll know that that's probably not a perfect amount of regain or weight loss following this procedure. It is something, and it is certainly helpful for these patients. So in conclusion, obesity is a multifaceted disease. We need a comprehensive approach to the disease, which I feel like we have here at UW and are continuing to build upon. And endoscopic bariatric therapies, specifically the ESG, are becoming more widely accepted with longer-term data. So this is just a plug because I know there's going to be questions about how to refer people for these procedures. Courts insurance has been playing really well with this. There's also an out-of-pocket option, but in individuals with a BMI greater than or equal to 30, essentially, if they're interested, I would be happy to see them. And they're usually referred through the website, which you could just Google bariatric surgery. We're all on that website at UW. So that's all I got.
All right, great. Thank you so much. And I will take the chair prerogative and ask the first question. So Dr. Harris, you mentioned the New York Times feature of the biggest loser. So that's where I get most of my medical information as well. And they recently had a feature about the use of bariatric surgery. You know, what is the role of bariatric surgery in the adolescent population? So what are our practices here? What are your thoughts on age limits? When should we consider it in adolescents or children, et cetera?
Yeah, that expose in the Times, I think they've had a series, I think by the same author, of oh my God, surgeons are doing terrible things, whether it be abdominal wall reconstruction, operating early, or I can't remember the latest one, but
It was an NYU thing, right?
yeah, the NYU thing. So essentially, the sooner you get to someone with obesity and diabetes, the more health span that they will gain, the better their outcomes will be before they have, beta cell dysfunction versus beta cell like death, right? Or lack of beta cell ability to release insulin. So we know that. There is a really well-established literature in the adolescent population of the safety and efficacy of bariatric surgery. Patients lose more weight. They have better durability in that weight loss. I think for a long time, we've tried to establish, I started here in 21, so even predating me, we've tried to establish an adolescent program here. And there's just too many little barriers to overcome so far. But, ultimately, where I was in Boston, we were doing it. They're doing it at Cleveland Clinic, Associated Rainbow, and Cincinnati is a major center for that. And at Denver, they're starting a major program, and outcomes are good. Clearly, there's a lot that goes into operating on a child, and you need to have buy-in from parents. You need to have buy-in from the staff who work with those children, and that kind of is overcoming a lot of biases.
Very good. Well, I'll ask the next question, if I may. I'm going to put it to you, Andy. It's such a broad question that I have to ask you to try to really be pointed in your answer. So we're looking sort of one or two, three quick steps to answer this question. How do you recommend dealing with the weight gain that occurs in some of these patients, the relapse as put here? So the person has gone through either your procedure or Dr. Harris's procedure or some combination, lost 10 to 20% of their weight. 2 years later, they're only 5% down. What would you do then?
Sure. Yeah, so I think a couple things. One is really looking to see if they have followed up with the appropriate nutrition, psychological, that we're meeting all those things, ruling out other reasons why they didn't lose their weight, right? Which could be nutritional, psychiatric, or medical. Did they develop a GG fistula, for instance, right? So those are all important things. And then it kind of depends on, well, what was the procedure they had in the first place? Is there anything we can do, like in the example I gave of doing a TOR following bypass? And I think in general, if you see patients who don't fit any of those other things, right? There's no alternative reason for that weight gain or weight regain or recurrence. Then that's where medical therapy can really come in handy, I think. And we're seeing more and more data suggesting utilizing both and how you can really achieve some dramatic numbers.
I have now a question for Dr. Harris, because two people, Trevor McCown and Steve Barcy, independently asked the same question, which was prompted by your references to improve cognition after weight loss. And they both asked how this might relate to obstructive sleep apnea. And I wonder, have you thoughts on that, and are there data on that?
Yeah, that's a great question. So there's probably about 25 very small preclinical studies, and I don't recall any of them actually controlling for that. And certainly the best therapy for sleep apnea for cure is bariatric surgery. So it's something that really has to be taken into account. In the preclinical world, so in the mouse world, like for instance, the study I showed, the mice have pretty identical weight at the end. And so there shouldn't be a difference in their respiratory physiology, but there's still a change in cognition. And we can see actually a reduction in plaque formation and tau formation, which I didn't present. So, there is clearly a role that sleep apnea plays. You need a stratified study. I've been trying to get access to Cosmos, which has millions of patients in our EPIC system, which UW, I think, only recently signed in to get, to kind of answer those questions, because you need a large data set to kind of like stratify based on those things.
Another question for you, Dr. Harris, and it's really quite a specific question. you presented the statement that Asians with a BMI of greater than 27 should be considered for surgery. And the questioner asks, could you stratify what you mean by Asians there? South Asians, Indian, persons in origin versus Chinese, for example. Is it the same across all groups from Asia?
Yeah, I think it came from a study in diabetes care in the mid-aughts, and it's Far East, Southeast Asia, and Indian subcontinent. So it really is essentially anyone of quote Asian descent and who identifies as Asian that the guidelines are based off of.
Okay. So a question for you, Andrew, is does gastroparesis have an effect on either eligibility for endoscopic procedures or the subsequent use of medications for weight loss?
Yeah, that's a really good question. So I would say that it kind of depends on, let's talk about endoscopic therapy first. I would say that maybe that might not be the best approach for that person, right? So the mechanism is kind of slowing gastric motility, right? And so if that's already at play, you might not get those weight loss numbers that I've kind of illustrated, right? For the medication side of things, but I will say that person might benefit greatly from getting a laparoscopic sleeve, right? Because that does speed up gastric emptying. The medication side of things, I think there's a lot of unknown there. I would not, if somebody's not significantly symptomatic, I would not hesitate to put that person on a GLP-1 just because they have gastroparesis. I have a patient on a GLP-1 right now who has gastroparesis, and he's doing fantastically. So because that is a side effect of the medication, doesn't mean that I would not use it in that case.
Okay.
Yeah, they should really get bariatric surgery because all operations increase gastric emptying. And so they're going to get the biggest bang for the buck. And gastroparesis is a really tough disease to treat. But I mean, those are the two operations. I typically start with the sleeve, and if they can get one, if they don't have bad esophagitis or Barrett's.
Yeah. I have one last question, if I may take the question asker's prerogative, and that is, would you each give an opinion of the other person's procedure? So, Andrew, what do you think of surgery? And David, what do you think of this endoscopic idea?
Yeah, I have to go first.
Yes.
No, I'll be really nice. No, I honestly, so I would say the majority of patients I see, I recommend surgery. Surgery is the best approach we have. If you qualify for it, that is the best thing you can do. And that has been documented, and we have long-term data suggesting that, durability data. It's a no-brainer to me. It is for patients who otherwise would not qualify, or who may not be eligible, that I really do consider the endoscopic sleeve to be maybe the next best thing, depending on the patient.
David, what would you say?
Yeah, so I think that every weight loss program needs bariatric endoscopy. I mean, where I came from, bariatric endoscopy was really strong, and there were like 5 or 6 providers. And I think the reason being is that we cannot impact enough people. Bariatric endoscopy has a clear role to play. There are patients that don't want surgery, and that's okay. And then they're okay with endoscopic therapies, and endoscopic therapies have the durability. You do an hour and a half long procedure, you infect the patient forever. So whether that's 20% or 17% or 15%, it doesn't matter in terms of total body weight loss. You're impacting the health of that patient. And we bail each other out a lot, right? Hey, there's this complication with the bypass. Can you help us out? Or, hey, our endoscopic sleeve didn't work. Can you convert them to a bypass? So they're all really a synergistic life. Now, there are other endoscopic therapies he didn't mention that I don't love, but we won't get into that too much.
Lynn, would you like to give a final thought?
Yeah, I think thank you for the great overview. I am like, okay, everybody go to breakfast now, and we could know. But it's really exciting to hear about the long-term data for a lot of these procedures, and I think the needed shift from that weight loss, obesity is a medical condition, a disease, not simply a failure of willpower. And I think the biggest challenge is cultural, of how to change that mindset throughout the country in this. So thank you for helping advocate for that and for everything that you guys are doing for our patients.